the long-term comorbidities and the long-term outcomes in ASD children. Now I invite Dr. Dedeepya from Fernandez CDC. She completed her MD in Pediatrics and did a fellowship in Development and Behavior Pediatrics from SRMC, Chennai. She leads the clinical team at Fernandez CDC. Her interest lies in the field of early detection and early intervention of global developmental delays, educating and counseling parents, and providing suitable treatment options. Now,
I thank the organizers for this opportunity. Today my talk will be focused on heterogeneity in autism. The criticisms in DSM-5 to understand how it impacts the outcomes, background of aging and autism, the health, brain and cognitive and quality of life outcomes, what's the way forward, what are the prognosticators for the outcome of autism, and some key points at the end. So as we all know that autism has evolved over time and now it's used as an umbrella term for a lot of neurodevelopmental disorders. So as explained by the early speakers, about one child having the same symptoms and the other child also will have the similar kind of symptoms or outcome. So we need to understand the spectrum is really huge. And now the latest data shows the prevalence is 1 in 44, which is increasing every year. And a recent meta-analysis which suggested that the age of diagnosis ranged from 2.5 to 19.5 years, which is such a broad range of diagnosis of autism. And this data was collected from 2012 to 2019. And so I would touch upon some of the criticisms of DSM-5 because, and we will understand how it impacts the outcome. So the most common criticism of the DSM-5 definition of autism is the new criteria is too narrow. And it could result in excluding some individuals from the diagnosis of autism and therefore excluding them also from the access to the services. Another thing is the concern which we have with the that the 10 to 40% of the individuals who met the DSM-4 criteria are not meeting the DSM-5 criteria, which is a significant number of children. And another thing is the social communication disorder diagnosis. So it's a little unclear on how this diagnosis is related to autism, and is it a new diagnosis, is it under the autism spectrum, what are the treatment strategies recommended for this, and how is the outcome in this is still a little unclear. And some self-advocate organizations also argue that incorporating Asperger disorder into the category of autism spectrum disorders without any distinction from the autism will undermine the identity of the affected people. So coming to diagnosis of autism in adults, many adults are still undiagnosed because of the changes in the DSM-5 criteria over time. So it's very challenging to diagnose autism in the middle and the older adulthood because of the early developmental and the later compensatory skills. Added to this is complexity in diagnosing women as well, because there are a lot of camouflaging symptoms and they may not show up early, the repetitive behaviors which we commonly see. So women are often diagnosed later in their life. So having this basic diagnosis, let's see when was the first case diagnosed. It was way back in 1938. So it was Donald Gray triplet, and when he was 5 years, 1 month old, and he went on to be a lawyer and a school teacher. So he also had family, children, grandchildren, and he lived a fulfilling life. So having this background on autism, let's see how this affects the outcomes and aging. So as we know that the first case is in 1930s, and obviously all these people are aging in the last few decades. So the studies in aging and autism is very limited at this point of time. And there was also limited opportunities to study aging in adults. So the new CDC estimates that there are 2.2% of the adults in US with autism at this point of time. Obviously they were not diagnosed when they were young. So we can understand that the adults who are diagnosed with autism were much later, and that data is recent data. Coming to health outcomes, one large study examining the co-occurring conditions among 4,685 adults with autism versus 46,000 controls found that these people who are having autism have higher risk for epilepsy, gastrointestinal conditions like colitis, diarrhea, constipation, hypertension, osteoporosis, and sleep problems. And psychiatric conditions like ADHD, anxiety, depression, mood disorders, and suicidal tendencies. And a 6-fold increased risk in Parkinson's. So if we look at the links to Parkinsonism, Stakston et al. Examined Parkinsonism in 2 samples in USA and Australia, and they divided them into 2 groups. So the first group, if you see, they were taking antipsychotics, the other group was not taking antipsychotics. So 16% in the study who were 49 plus age met the criteria for Parkinsonism, and 17% of them not on antipsychotics met the criteria. So this shows there is a significant link to Parkinsonism as well. And in another Australian group, they found that 32% who are 40 plus met the criteria, and 25% of them were not on antipsychotics. So there is a significant link to Parkinsonism and autism, but it did not determine whether the link is associated with antipsychotics or individually as such autism can cause this Parkinsonism, because they didn't exclude them separately. So another study was done to understand this through self-reported data in Parkinson's screening questionnaire, taking 409 sample size aged 40 to 83 years adults, and they were excluded with they excluded the adults who are on antipsychotics, who self-diagnose themselves with Parkinsonism and other conditions which could also impact the rating of this, and they included 279 overall. And they found that 31% were showing positive for Parkinsonism symptoms and 69 were not showing. So 31% is a very significant number. So when they compared the Parkinsonism positive and negative group in terms of memory function, executive functioning, and quality of life, ADL and emotional regulation, they found that the first 3 there was significant lower in the positive group, and ADL and emotional regulation were not differed in both the groups. So Parkinsonism appears fairly common in autism, and especially in the middle and later adulthood, so it's very important to look out for this. Possibly more prevalent in women, and these symptoms are associated with overall poor outcomes in autism, and including the subjective quality of life, the memory function, and the executive function. Coming to brain and cognitive outcomes, as we have all seen, there is very limited data overall in adults, but the evidence shows that the autism group is declining faster than the neurotypical group. There is a difference in the cortical thickness as well as functional connectivity is less in adults with autism. Brain matter, if we see, there is decreased cortical folding, decrease in the hippocampal volume, there is decreased functional connectivity in the working memory and sensory motor areas, and also decreased connectivity between the brain areas. And there is increased radial and mean diffusivity in autism. Another study which they studied adults with autism versus neurotypical, they also seen similar age-related cortical thickness changes, and there was a decrease in the white matter microstructure. Unfortunately, there were no longitudinal studies to prove that this is how it's going to be in everyone. Coming to cognitive aging, there was subjective executive functioning deficits in older adults with autism, and there was negative age correlations with cognitive performance and visual memory and learning. Again, there are no longitudinal studies, and so everything is very unclear at this point of time. Long-term follow-up studies of outcomes with autism was done in toddlers to teenagers, which examined the developmental changes and the predictors in about 65 of them. And they were divided into 2 groups, the high cognitive and the low cognitive groups, based on the DQ. And they found that the high cognitive group had significantly less social communication deficits, better adaptive skills. So the better adaptive communication skills in toddlerhood were associated with better outcomes in adolescence as well. So cognitive potential of the individual when we see early can have a strong prognostic value in adolescence. Another study by Dedeepya et al., which was a prospective study, compared outcome trajectories in 3 adolescent groups based on the cognition and the severity. They took a sample size of 68 and divided into best outcome group, high functioning and the low functioning based on the cognition and severity. And they found that there was a significant improvement in adaptive skills and cognition in the best outcome group, compared to high functioning group, which was showing only partial improvement, and low functioning did not show any significant improvement in their study. But there was no significant difference noted in the prevalence of the medical problems among the group. Coming to quality of life outcomes, 2012 the National Autistic Society survey, they have surveyed 355 adults who were 45 years plus, and the results showed that 66% of them never had their needs assessed since they were 18. So after 18 there was no follow-up of these adults, and most of them relied on family for their support. There was whoever had lack of support felt isolated, and 33% go weeks without speaking to anyone outside their household. Another study among 55 plus year adults with autism showed that there was a divergence in the objective and subjective quality of life. So what does that mean? If we see from outside, probably this adult would be going to a job or having a family and everything going on well. But if you ask them personally how they are feeling, they would say that I am not happy in my life, I'm not feeling this, I'm not feeling satisfied with what I'm doing. So this was the outcome of this study. And co-occurring mental health conditions detrimentally impacted the quality of life. So aging well in autism, when we look at, we should not only look at, okay, are they going to school, are they getting a job, but also we have to look at how they are accepted, how they are included in each and everything in the community or the life or the society. What are the problems and pitfalls with all of this? So the cohort issues are substantial in sense that the changes in autism diagnostic criteria was changing over time, and there was differences in the history taking as well. And study recruitment was also very challenging in these groups. So these were the pitfalls. And so what do we need at this point of time is cost-effective gender-specific research and diagnosis to support decision making. So it's now the research is showing that males and females also have different characteristics. Maybe it's not the same, and the age of diagnosis for a male and female also is different. So we need gender-specific diagnosis, engagement of stakeholders in the intervention, development and deployment, personalized and developmentally targeted interventions over the life course, culturally adapted and tailored family-based intervention approaches, use of more advanced research designs to help answer all our complex questions over here. So coming to prognosis of a child with autism. Now this is a very, very big question, and everyone wants to know what happens to the child when the child is diagnosed with autism. Especially for a parent and the family, it is a very, very challenging situation. First of all, as one of the parents mentioned, it's very difficult for them to accept the diagnosis, understand what it is and how to go about it. So for professionals as well, sometimes it's challenging to disclose a diagnosis to a parent, because the parents, as it has come in a stressful situation, oh my God, my child is not talking, my child is doing all this, don't tell me it is autism. Now we are very worried, how do you disclose this to a parent who's already so stressed and worried, and how can you help this family in planning the intervention? So it's a very tough and challenging part, and so because of the great variability in the long-term outcomes, and it's very important to acknowledge that the heterogeneity of autism within the individuals, also within the lifespan and between the individuals. So evidence shows that in less than 4 years, non-verbal intelligence, joint attention, play skills, age at when the intervention was started, and the cumulative hours of intervention is what determines the prognosis of a child. And when I mean by age of when the intervention was started, it's not the age of diagnosis, but actual intervention when it was started. Because there is often this lag in between when the diagnosis is done and when the interventions are started. And also the cumulative hours of intervention, as Dr. Pratima mentioned, there are certain recommendations that this is the number of hours you have to intervene for a child to show a good outcome. And often it's very difficult for the families and the therapists to work continuously with the child. So that is the reason why parent intervention and parent involvement becomes very important in the outcome. Coming to 4 to 6 years, improvement in cognition over time, functional expressive language becomes an important prognosticator for it, and restricted and repetitive behaviors, comorbidities and sensory issues are negative predictors. So some of the things which also can have a prognostic value is family resources, education of parents, community which they live in, and the geographical region. So why this becomes important is the access what we get. Leave about US and India. Even in India, if we see each state to state, it's different. Even in Hyderabad, if we have so many centers. But if you go to district level, there are no proper centers. So we are diagnosing these children early. But what is happening to these children? They are going back to their place. They are trying something. But ultimately, the outcome is not improving because of the access to the services and the understanding of how to intervene with the child. Again, the genetic conditions which also play a major role in the prognosis. So some of the genetic conditions which are associated with autism, and we have the metabolic disorders, hypothyroidism, neurological disorders, immune dysfunctions, and feeding disorders, allergic disorders. So everything can have a prognosticator value in a child. So some of the key points, autism has extreme heterogeneity in outcome. Some children with autism do reach typical levels of functioning with proper intervention. Early diagnosis and intervention will make a difference. Trajectory of severity in autism is very important rather than one-point diagnosis. And non-verbal DQ at a younger age and verbal DQ at 4 to 6 years is very important in prognostication. Every child with autism can reach their greatest potential if intervened appropriately. And I just want to end with this thought of diversity and inclusion. We all think about it, but how accommodative are we about these children and families? I just want all of us to think so that this place becomes a better place for the children to live. Thank you.
In a systematic manner from US, and what they found is 5% of them grow out of the diagnosis. That if you retest them between 6 to 8 years, 5% of them grow out of the diagnostic label, become independent, they are going to regular school, they don't require any of the therapies. So you're looking at 35% of these children who are independent, 5% out of the label, 65%, which is a overwhelmingly large percentage of population of children with ASD, will continue to require some form of support. So we are actually trying to do something like this in Hyderabad. I think all the billing centers can try to this one. We are proposing our study in Rainbow. So if anybody, any centers with large volumes would like to participate, we would like to review if you have the baseline data at 2 years to 3 years of their IQ, of their performance, then between 6 to 8 years we are going to reassess them for their school integration, need for support. So at least this information, if it's going to come out from our own centers, our own this one, which is applicable to us. What is applicable to US may not be applicable directly to largely you can say this is what is available, but I think we can generate this information. It's not very difficult. We should be able to do it, and in 2 years time we should be able to tell this is what happens if you do these therapies, and within India, within the resources available. I think that is the long-term goals. So I think I'll request any of us, you can contact me and then we will be part of the study. Okay. Thank you.
Time presentation. I request Dr. Lokesh sir to facilitate Dr. Dedeepya.